Hello, everyone. I'm Dr. John White. I'm the Chief Medical Officer at WebMD, and I want to welcome you to today's webinar. It's entitled The Future of AI in Patient Engagement, an expert panel discussion. And it is going to be an expert discussion. I'm excited about our panelists, and I'm going to be the moderator for today's session. Now, before we get started, just like to take a few seconds to go over some housekeeping items. The webinar is being recorded and will be available in the coming days on demand. So folks, if they didn't get to join today, will be able to watch later. Now, taking a look at the console in front of you, is there are a couple widgets I want you to know. Just below the media player is a Q&A widget. If you have any questions at any time during the webinar, please go ahead and submit them because we're going to have some time at the end to answer, and we want your questions because we want to engage you and involve you. And to the right, you'll see two resource widgets. One is a blog related to our discussion topic, and then another is about our new solution, Health Interactive. And please take a moment at any time during the webinar to fill out our 3-question survey, and your feedback is greatly appreciated. Now, second, some of you may not be familiar with WebMD Ignite yet, which is part of the WebMD family. So let me just give you a quick introduction. WebMD Ignite launched in 2023, bringing together many notable brands that you are probably already familiar with to revolutionize the health ecosystem, driving action, championing education, and really connecting at every touch point along the health journey. And if you have questions, drop me a line, be happy to tell you much more about it. And with that, I want to get started. And let me introduce the panelists. Their bios are available elsewhere, so I'm going to keep it brief. Joining me is Dr. Eric Topol. He's the editor-in-chief at Medscape. Mr. Eric Smith, he's the Chief Digital Officer at Memorial Hermann. Dr. Aladad Gyasi, he's the Chief Medical Officer at HIA. And Dr. Jesse Ehrenfield is the President of the American Medical Association. Thanks for joining me, everyone.
Great to be here, John. Thanks.
Thank you.
Now, I want to start with, where do you think AI holds the most promise for use in patient care, and specifically in patient engagement? So is it diagnostics? Is it scheduling? Is it decision tools? Is it symptom checkers? Where does it hold the most promise? Who wants to start? Maybe we'll begin. Sure.
Dr. White, let me just jump in. So I like to think of it in two big, broad buckets with some grays in the middle. In one bucket, you have tasks that are time-consuming, repetitive, mundane, require a lot of attention and human effort, and they take a lot of time. And on the other bucket, you have, and I call those, the possibles. Those are the ones those are the implementations you're going to see initially, like EHR integration or Copilot or patient engagement solutions. And as we move up this hierarchy, you have tasks that are really the impossible. And AI is going to make the impossible possible. And by that, I mean the merging of AI with synthetic biology, predictive analytics, diagnostics. And in the middle is the zone of things that are kind of in transition, but the initial implementation is going to be through these low-level tasks that are taking a lot of time in healthcare. And that's kind of how I see the progression of implementation of AI as we move forward in the next 5 to 10 years.
What I would say is that fully autonomous AI is really concerning to the public. There are a lot of technical challenges. There are a lot of regulatory issues. I think where the money is around augmented intelligence, supporting data synthesis, supporting interpretation, supporting decision-making by clinicians and patients. That's where their opportunities are right now. And we have clear data because the AMA does a lot of practice surveys. Nearly 1 in 5 physicians are currently using augmented intelligence today in their practices, but it's for practice efficiencies. It's for back office operations. It's for supply chain management. It's for scheduling. But people are enthusiastic. 2 in 5 tell us that they plan to adopt it in the next year. So I think you see this desire, but how the tools get integrated into practice is going to be dependent on so many costs, so many issues, liability concerns, what happens when something goes wrong, and making sure that you've got the right evidence to support their use in an individual practice.
Yeah, and some of them are using it, Dr. Ehrenfeld, whether they know it or not. Sometimes physicians aren't even aware that AI is being used in some of the components of their practice. I want to turn to Dr. Topol and see if he agrees with what folks are saying in terms of where's the promise of AI. Because Eric, you and I have talked about it over the years. Where do you see the promises in terms of patient engagement?
Well, it's not just a promise, it's already well underway, but it's a far-reaching objective, which of course would be to restore the patient-doctor relationship and get gift of time and that human bond. But right now, as you know, we have two big fronts of patient engagement with AI. For one, there's many coaching apps for things like depression, diabetes, hypertension, obesity, where AI is coaching and then there's a human in the loop. And there's at least 50 of these that are getting more and more popular. In addition to that, there are many AI apps. The first one that was approved, deep learning app for consumers, was the smartwatch diagnosis of atrial fibrillation. And now that's been expanded to other arrhythmias. There's also, not just in the US, but there are AI tools to diagnose, self-diagnose, urinary tract infection, skin lesions, skin cancer, ear infections in children. So from the patient side, AI is already there. This is unimodal AI. This is deep learning, not transformer multimodal models, but it's already gotten started. And it's one of the problems we have with AI is always looking at it from the standpoint of physicians, when in fact, patients can go to ChatGPT today to get information about a potential diagnosis or have conversations. It's not going to be regulated. Google isn't regulated, or WebMD isn't regulated for medical information. So there's lots of promise ahead with the new tools, particularly transformer models, these large language models, and multimodal AI. But what we've already seen in recent years is not anything to be dismissed.
Yeah. Well, let's keep in mind there's news very recent about the government's interest in really looking at AI more closely. So it remains to be seen, Eric, where we'll have regulation. But I want to turn to Eric Smith and hear your perspective on where you think the real promise is in AI. And are we there yet?
Yeah, I think we're getting there. And I think the comment that was made earlier about some of those more simple tasks, I think there's a lot of value in helping to solve with AI, helping to solve those tasks and to actually create more engagement on the part of the patient. So if we have the ability to reach out to them at scale, to have them be more of an active participant in their health, whether it's collecting data, checking in on them, things like that, I think it gives the providers scale and allows them to focus on the patients that maybe have a higher level of acuity or higher level of touch, but still keep that patient engaged in management of their health on a daily basis.
Yeah. And I want to turn back to something that Dr. Ehrenfeld said. I liked the use of the term augmented intelligence that many people are discussing right now. Yeah. Tell us how you think that's going to help really enhance the provider's role. Is that the opportunity to see more patients during the day? Is that the opportunity to have a shorter differential to help point in the direction of care? Where exactly does that idea of augmented intelligence help?
Yeah, let me just speak to Dr. Ehrenfeld's comments, by the way, and regulation. Mm-hmm. I truly believe that the core of this is agency and authority on the data and information, right? And we have to keep that in mind. We as clinicians have that authority and agency, and we don't want to turn that over to a machine. I don't see that happening anytime soon. As a matter of fact, I don't believe, at least in healthcare, machines are going to replace humans. And to your point about this augmentation, which is a wonderful term, I use that all the time now as opposed to artificial. It is augmenting the most valuable resource in healthcare, which is time. As you know, practicing physicians, nurses, doctors are always under pressure for time. And that visit now has become this data exchange with a computer as opposed to the human element, which is, involves talking to a patient. So I think it's going to improve the time scale. And that's really any technology that provides that for the clinicians is going to provide value for the healthcare system.
And look, the way that we advance care delivery is to combine AI tools, systems with that irreplaceable human, that irreplaceable clinician. And when you combine those things together, then you get outperformance of what either can do alone. I don't think it's right to see this as a zero-sum game of physician versus machine, but we've got to be forthright in addressing the challenges in the design, in the evaluation, in the implementation of these technologies as we think about how do we integrate them into the delivery of patient care. And there is an opportunity for AI to offer a transformative set of tools that can help us address quality and cost challenges, time challenges. But we've got to make sure that we've got the perspective of physicians included so that we use these things widely and that they benefit patients. And what I mean is that the physicians have to actually be in the loop of the design and the implementation and involved in the fabric of oversight so that we can ensure safety and equity and effectiveness.
Well, that brings us to the point of implementation, because you all have discussed in a positive way the promises that you think AI can deliver. But we know everything costs resources in healthcare. And there's been numerous studies recently that have talked about, everyone is talking about AI, but probably only about 10% of healthcare organizations have an explicit plan how to implement it. So I want to raise that issue. What are some of those considerations for organizations before implementing AI tools? There's the issue of cost, there's the issue of physician engagement, patient engagement. What are those considerations that organizations should consider before they implement some of these tools that we're talking about?
Yeah, it's interesting. There's an article in the New York Times today with Jesse and I weighing in on this problem. Basically, there's now 630 FDA cleared or approved medical AI algorithms. And almost all of the data for all those algorithms has never been published. It's not at all transparent to the medical community. And the data sets are often typically retrospective, weak, small, no less opaque. So implementation is hampered by lack of compelling data, lack of the transparency. And that's why, John, there hasn't been much implementation, and there won't be until there's really very compelling data where the medical community can review that. And so, hundreds of algorithms in particularly certain domains like radiology, cardiology, and others are sitting there just because there's too many obstacles. You mentioned cost, but there's just about the ability to review the data. And of course, there are some exceptions, but for the most part, these are not strong evidence for moving forward.
And so many of these tools are proprietary by nature. There's no mandated transparency requirements. So that makes full understanding from a physician of the training considerations, the performance characteristics difficult or impossible. There was actually a really recent study in Nature Digital Medicine. They tested 5 different large language model implementations. And shockingly, they found that some of these tools actually reinsert race as a variable into an eGFR calculation for kidney function, which we know is obviously problematic.
Yeah, Eric Smith, you're the chief digital officer at a big health organization. What are your thoughts? How do you consider whether or not you're going to implement some of these tools? What do others need to consider? What have you considered?
Yeah, so our actual focus primarily has been on the patient engagement side and really sitting with our physician community and understanding, hey, what are things that are taking time from you as far as the way you're engaging with patients, the needs that you have, information that you have, that we could go utilize some of these tools. I think for us, we see it as a bit of a safer approach to test and learn. And as part of that process, we'll we'll pilot a number of capabilities, roll those out, and a couple of things. One is we have extensive auditing to where we understand how that engagement is happening and what the patient response is. But we also have a human in the loop as well, to where if the AI appears to be going off the rails, so to speak, we have the ability to get a human engaged to make sure that we continue on with that conversation and address any issues that maybe the AI had.
Yeah. And then Dr. Yadi?
Yes. Yeah, sorry.
Dr.
So can I speak to regulate? One of the issues with these large language models, as everyone knows, is transparency. Even the best data scientists, the best computer scientists in the world can still figure out why it gave a reply that it did. So that's an inherent, I think, obstacle that we have to overcome in order to impose regulation on these language models and the data sets. For instance, if a language model says I should have surgery and the doctor says I shouldn't have surgery, how do we know who's right and who's going to be the agent here to actually take control of this narrative? So what we've done at Haya Technologies is we've taken these tools, but we don't expose them externally to our patients and to our consumers. We actually use them internally to improve efficiencies and really use them to understand where the patient is in their healthcare journey. We use sentiment analysis or tools like semantic similarities to really understand the core nature of that interaction, the question that's being asked. And the output that comes out is curated by physicians who have certain protocols, certain ideas, certain thoughts. So it's a very controlled environment. We call this technology physician-controlled AI, which leverages the power and ability of general AI tools, but does not expose them externally to the patient. So that safety and guardrail, I think, is paramount in rolling these out. And this is one of the things that resonates well with our clients and customers, because they're looking at this technology going, yeah, it's not going to go rogue. It's got these guardrails and limitations around it that make it digestible and understandable as well. So
I want to come back to another term, if I may, just so we level set everyone. Can you explain the difference between generative AI and closed AI? Just give a reminder, a little quick primer.
Yeah. So, generative AI is essentially a computer algorithm that has been trained on a large amount of data sets. We're talking billions and billions of parameters, either from the internet or through other digital means. And it's been trained and aligned and formed to understand the mechanics of language, essentially. But just like humans, it has flaws. As you know, people have heard stories of the generative AI hallucinating, making up stuff that's not completely real. But by that same token, it's very powerful because it can look at a large data set and understand and obtain from that what is the meaning in that data set. A closed AI system is really a hybrid model where generative AI looks at the data set, curates that, comes up with a formulation as what the intent of the person is within that environment, but allows the clinician, the author of that content, to produce an output that's consistent with their narrative. This has been shown, by the way, there are a few startups that are using this hybrid model where they're actually using generative to leverage an output that's consistent with their narration.
When you think of any technology, look, there's always trade-offs, value decisions, societal considerations that you have to make. And AI, large language models, they're not just technologies, they're socio-technological systems. Yes. And we have to look at them through that lens to get it right for medicine. And so I'm super excited about what these technologies will bring, but we have to understand where they exist, even if we don't understand what they're doing. And so I think we all need to agree that there may never, ever be the opportunity to have completely transparent models that are understandable because of the deep learning and what's happening. But we ought to at least understand that there is a model running somewhere if we're going to rely on it to make a clinical decision or drive a ventilator or help optimize some clinical decision making.
I want to ask all of you, though, do we hold these new tools to higher standards? So we talked about that concept of hallucinating, making up information, right, in terms of generative AI. ChatGPT makes mistakes. AI can make mistakes in the algorithms. Doctors make mistakes. There's 800,000 preventable medical errors every year. But when we see some of the discussions around AI, we're all very positive today, but some of our colleagues are not. Dr. Topol, are we holding these tools to different standards in terms of the accuracy that we expect them to be able to do, in terms of the outcomes that we want them to implement? Can it be just as good, or does it have to be better?
Well, there's a lot to unpack there, John. So, the first thing is there's a difference between transparency and understanding, the big field of explainable AI.
I knew you were going to like that from Dr. Ehrenfeld. That's
yeah.
okay.
Well, the issue there is there's a lot of things we do in medicine, treatments that we use, that we don't understand how they work. Okay, but we use them because the data, the evidence is very strong, and so even though we don't fully understand it, we use it on daily practice, and there's so many examples of that. Now, with the new models as generative AI, we have another problem. One is that the base models from the large companies, there's a very small number that have really made these, like the Google and Meta, Microsoft, OpenAI. There's a limited number that have these base models that have cost hundreds of millions of dollars to train. Have used 20, 30,000 graphic processing units. Now, they aren't transparent. They even have a new name, frontier models, but they also don't understand them. Nobody understands how these models do so well or exactly how they hallucinate. That's different from transparency. And that's the feature and the bug that needs to be addressed. So let's just make sure we separate these two issues, because what I talked about earlier is transparency with respect to proprietary data from companies that are marketing algorithms to health systems or to consumers. But let's say we have randomized trial using multimodal AI that shows it saves lives, it's unequivocal, there's little risk, but we don't understand it. No, I don't think we should hold that to higher standards than medicine today, because if the data are extraordinary, then we're going to adopt it in medical practice. And that's something that, we don't have that yet, so we don't have to worry about it.
Eric, I really appreciate that point. I gave 19 anesthetics yesterday in the operating room, and I know how to use those medications for general anesthesia very safely. But in spite of millions of dollars of research and decades of work, we don't really understand the underlying mechanism of most of those drugs, but we can use them safely. And I think that's the right framework as we think about these new technologies.
Well, Dr. Ehrenfeld, what resources are available from the AMA to healthcare organizations to evaluate these resources, to implement them? So what's currently available?
We've got a whole bunch of initiatives. We want to make sure that physicians have a seat at the table when these new AI-powered innovations are still in the design stage. We want to bring physicians, developers together so that we can get the best healthcare technologies, things that can expand the bounds of science, things that fit into our practice, things that enhance patient care. We have a framework for healthcare AI. It's available on our website. We also have the new CPT AI taxonomy. Again, as we respond to all the innovation that's happening, our CPT
that is a good one, the CPT taxonomy.
Really, really, really important, because you need guidance, right, for how do you classify these very powerful AI tools, medical service applications, expert systems, so on and so forth. So the new AI taxonomy establishes kind of those foundational definitions so we can have some shared understanding around the ecosystem about what are the technical features and performance of these applications.
And Dr. Gyasi, I'm going to jump to one of the questions from the audience right now, because I piqued their interest with this Health Interactive. So they wanted to know more about that. And I thought perhaps you could talk about what you're doing, also what you're doing with WebMD and WebMD Ignite in this space.
Oh, yeah, thank you so much. So Health Interactive is really a delivery platform for content that has appropriate safeguards and guardrails around it to ensure that the output is fully controlled. And what we're doing with WebMD is really leveraging their content. They have, as you know, a world leader in healthcare content, and then using our platform to deliver that in an interactive way to our patients. So essentially, bringing their content to life, and that's not just the one value add. We also have back-end analytic tools in order to be able to understand what the patients know, what they don't know, where they drop off in the content, assess their comprehension, and really guide them through the healthcare journey. And the tool is so flexible that it can be edited on the fly for each individual physician, organization, or healthcare provider. And it's been really, a tremendous partnership here to bring those two elements together.
I love your point about the patients, and I want to turn to Eric Smith and get your insights into, we've kind of talked about what physicians want in terms of the use of AI tools, what organizations want. What do consumers want? What are they saying they need? And how are you addressing that?
I think at the end of the day, the consumer or the patient is looking for information. So they're obviously going to things like ChatGPT, they're going to Dr. Google, all the things we don't want them to go to because of accessibility and the fact that they can ask their question on their terms, in their time frame, and when they're looking for the information, not just when we're available, right? 8 to 5, Monday through Friday, or whatever. And so they're looking for that level of convenience at the end of the day. And I think this is probably a little point of contention, but I think consumers and patients assume that there's a lot of information that we have about them. So use that information to help guide me, and use that information to and allow me to access that in a way that is actionable for me. So I think that's our opportunity, is to say, okay, how do we then turn that into an engagement opportunity to provide that information for them? And I think that's where AI can do that and allow us to do that at scale, but in a guided way, and in a way that's managed by the provider and not managed by something that we may or may not know as far as what the source of data is.
I have to say, we have some real issues, though, with consumer trust. And, there was a really nice survey. 70% of adults in the U.S. have concerns about increasing the use of healthcare AI, dependent on the type of the task that the AI is performing. Patients want important healthcare tasks led by a member of their healthcare team, not the machine. And I think that's why we saw the administrative action by President Biden yesterday, and the executive order trying to bring a whole of government approach together to make sure that we have confidence in these tools across industries, but particularly in healthcare, because people really want these tools, but they want them to assist rather than replace their doctor.
Yeah, and I think I love the word trust, because I think that's exactly what we have to back our way into, is to develop that trust over time, to where there's confidence on the part of the patient, but also confidence on the part of the provider that it's guiding their patient in the right way. And I'm 100% in agreement that this is an augmentation and not a replacement by any stretch. And there always needs to be that option to where, if I'm not comfortable, or if I just need some empathy at the end of the day, I have the ability to transition from that modality of AI to a human to actually have a conversation and to take a next step.
Although keep in mind, Eric, some recent studies have shown that ChatGPT, depending upon the question in a text-based form, as you know, people felt it provided more empathy than an actual physician response. But these are all issues that we're going to address. But I also want to go back to this issue where you mentioned about consumers, patients feel we already have a lot of information about them. Personalization, that's what we all want in terms of care, right? Care that's unique to my individual needs. But then there's the issue of privacy, right? Don't be giving my information everywhere. Health is intensely personal. How do you balance personalization versus privacy when you're using these, augmented intelligence tools?
Yeah, so it's like having a conversation with my privacy office here. No, it's a very fair question at the end of the day. And I think that's one of those things so I come from outside of healthcare and come from financial services. And although healthcare data is different, there's still a lot of parallels with my financial life, which is very private and very individual to me. and decisions I need to make, and healthcare data about me. And so I think there's, going back to that word trust, I think there's an opportunity for us to develop that trust, but also ensure that the way we are using that data ensures that privacy on the part of the patient. And I honestly think that's our responsibility to do, because of the fact that the patients may not realize that if they are asking the questions in ChatGPT and putting some of that information out there, they don't know what's happening with that data and how that data is being used. So I think we have to provide those guardrails with the solutions that we either identify or build internally, and to be able to put those guardrails in place, which over time I think develops that trust.
Data privacy is so important. We are so deeply invested at the AMA in making sure that individual patients are protected, that they're not discriminated against, and that they have assurances that are guaranteed. And ultimately, that responsibility is going to fall with the data holders. I think a real challenge for us, it's unlikely that a physician or patient is going to have any clear insight into a generative AI tool's conformance to any state or federal data privacy laws, right? Because these large language models are trained on data scraped from all sorts of places that can include HIPAA-covered environments, yet there's so few controls available to help users protect data that they're voluntarily entering into a query. So this is something that is obviously concerning to us, particularly as we think about what is the definition of de-identified or identified information in this context.
I know I said we'll do questions at the end. I did just want to jump into this one question here, because you're all talking about, how it can augment and help. And one of the questions is, how about the staffing crisis? Will AI help healthcare there? Dr. Topol, you were about to talk, so I wanted to give you a chance to respond to what you wanted to, and then ask you about the staffing issue.
Well, I just want to point out, John, that the data problems are much deeper than what has already been mentioned. Patients don't have their data. They don't own their data, which I believe should be a civil right. But it's complicated because a lot of data isn't in electronic health records. It could be their genome, it could be their sensors, it could be their environmental exposures. So we have, and of course, fragmented care, where there's many different places where their data resides. And so we haven't done anything to favor the patient empowerment. And in the world of AI going forward, it's all about input. And when you want to have multi-layered data and you only have a little bit of what you can get out of a portal, which is still not the actual raw data, like the scans and whatnot, it's a problem. So I think that should just be acknowledged, that should be a direction. There are countries in Europe that have moved in that direction. The US hasn't done anything to promote patient empowerment by ownership of their data, while at the same time, there have been serious problems with cyber thievery, hacking. The vast majority of Americans have had their medical data compromised. This is not acceptable, and something should be done about that, speaking of trust. Now, with respect to the question you asked about staffing, there's an illegitimate fear that all of a sudden, doctors and nurses' jobs are threatened. I think a New England Journal recent review showed that almost all of the action so far in AI in healthcare is administrative, coding, billing type facilitation. There hasn't been a lot of reduction in any staff across health systems because of AI. There may well be some in the future, but I don't see that really affecting clinicians. We have shortages of clinicians, which have been exacerbated by the pandemic and burnout. And so I don't see that as a threat at this point.
But AI presents a tremendous opportunity, John, because you think about the workforce that we don't have today and that we won't have in the future, because we haven't expanded GME, we haven't done all the things to keep pace with the challenges and the pressures. I think we're going to be dependent on these technologies to help us scale capacity. You look at the first autonomous FDA AI-approved device in the diabetic retinopathy space. Beautiful little set-top box. You can put it in a PCP office. You can put it in a retail pharmacy. It has such good image recognition capabilities to diagnose diabetic retinopathy that the company carries malpractice insurance on the device. Now, suddenly you have millions of diabetes patients who need an annual eye exam. They can get it. And suddenly you have ophthalmologists, their workflow can change. They don't have to do the normal exams. They can just see the patients with the disease. It scales capacity. We need use cases like that. And I think to solve the workforce crisis that we are in right now, we're going to be relying on these technologies.
And let
Dr.
me just
Diaz,
speak to
what's your
that.
perspective?
Yeah. Yeah, no, I mean, I think this is really important. AI is not going to replace humans in this space, especially in the labor constrained environment that we're in. As a matter of fact, this speaks to trust as well. If we have AI tools that liberate the clinician, the nurses, the doctors to be able to do actually hands-on care, then that's the way to build trust. So what we need to do is design tools that unload the doctors to allow for that one-on-one human interaction to happen. And one of the solutions is really in patient education is to have those conversations beyond that 7-minute visit. And this happens all the time. You know, it's in this cold, scary room. You're sitting there not listening to the doctor. You have no idea what's going on. And they're just talking to you. So really being able to augment the clinician's brain trust through control AI technologies is a wonderful way of unloading the physician and also the patient, because you know they're anxious, they're nervous. This happens in my practice. I don't worry anymore if I forget to tell them about something, because I have this tool that speaks for me, and I've given it agency and authority to speak for me without me being there and without me worrying that it's going to go and be rogue. So 100% agree. AI is not going to replace anyone's job. As a matter of fact, I'd say in the past 20 years, clinicians have become data entry people, which is a complete waste of that talent and effort. And now we have to get them back to the actual physical part of what they signed up for, which is human to human care, one-on-one care at its best effort going forward.
Well, that brings up another question that came up as to what's next in terms of AI in healthcare? What emerging trends do you see on the provider side? Because you're all talking about how it might help in terms of workflow, in terms of algorithms. So what's next there that
John,
you're
I think
excited about?
There are 5 shifts we're going to see. We're going to go from digital to smart tech. We've just digitized healthcare paper, but that's not meeting our patients' needs, right? We've got to employ smart tech algorithms for data-driven analytics. We're going to see a shift to social determinants of health. We know that there needs to be a greater emphasis on addressing social determinants. That's going to happen. We're going to shift to interactive platforms. We're seeing this with engagement platforms, future interactive healthcare that can create more meaningful relationships to establish trust. We're going to shift to closing the knowledge gap. This is so crucial so that we can empower patients in a different kind of way. And we're going to see a shift to more real-time feedback tools that, again, is going to help people more engage with their own care.
Yeah, I just want to get to what's exciting in the immediate term, John. I think that was what you're getting at. And that was already touched on, which is moving towards keyboard liberation, trying to eliminate or markedly reduce the data clerk function of clinicians. And that's exciting because well over 100 health systems in the country have started to implement or have done significant pilot studies in these ambient conversation, which make synthetic notes, not just the notes, which are better than the notes that otherwise have existed, but also doing all the downstream functions, including things like follow-up appointments, arrangement of tests, prescriptions, pre-authorizations, billing, all these sorts of things. So the fact that we've already seen hours of each day for clinicians to be reduced in their effort by AI tools, including nudging of patients about things that were discussed during a visit. This is a real exciting thing that it doesn't require randomized studies.
Sure.
It doesn't require regulatory review. And if it works as well as we're seeing right now across many health systems, this is a big advance because this is one of the fundamental problems of the poor morale among clinicians, which are data clerk roles.
I just got to tell you, I know a colleague who described how she cried when she got one of these ambient scribe tools installed because she made it home to have dinner with her kid for the first time in months and her family. And to give that time back, to remove some of these low value non-ads is, I think, where there's going to be real movement very quickly.
Yeah,
Well,
I would. We're doing active pilots in a couple of areas within our system, and just the provider feedback. It's changed the relationship and it changed the conversation they're having with their patient. They're actually looking at them they're actually reading signals that they may otherwise not have gotten because they're focused on the documentation side. So I think this will be an absolute game changer.
Well, Eric,
Yeah,
I
I
want to
think
follow up on
add-
that for Eric Smith for a second, because we talked about resources and other elements, and this question came in: how do healthcare organizations balance? Let's be realistic. There's a risk of investing AI versus the need to be innovative. So when you have, tight resources, how do you make that decision? How do you make that, determination? You got to balance. There's a risk of investing in AI. We're all talking about the benefits of AI, but not everything succeeds. What's your calculus?
Yeah, I think part of it is you look at where you can potentially get the most value, right? So this one for us on the ambient listening front, if we pull that thread through, one of the biggest complaints and issues that our providers are sharing is just the amount of time they're spending, pajama time that they're spending documenting. And so you double down on the areas to where, okay, yes, there's going to be investment we need to make and some innovations in this space that we need to go identify or build. But the lift, if we can be successful, is going to be many times whatever that investment was. So I think that's the way we look at those things. So there's clearly very simple things we can go find, but then you need to double down on the things that are going to really move the needle. And this is an example of one of those.
Can I speak about the ambient listening technology a little bit? I think it's fantastic.
Sure.
We've been, this is something that we've been waiting for a very long time. It absolutely frees up the clinician to have that face-to-face contact with the patient. They're not distracted. They're doing their job, which is taking care of the patient. But it also does pose a risk, in my mind, in the gaps in the knowledge that's being dispensed, right? So if I'm talking to a patient and I forget to tell them about a potential risk of a procedure, that's going to be now recorded in some session and it's going to be in the note. And there's some things to think about. How do you dispense that part of the conversation? And we all make mistakes, right? I mean, I've walked out of the room going, I forgot to tell them about, not getting their hand in the shower after the procedure. How do we bridge that knowledge gap? And I think one of the solutions is to provide them with additional resources that are curated by the physician, that are interactive, that have analytics behind them, that allow you to bridge that knowledge gap that is eventually going to happen. The other question about this ambient technology is it now the legal record of the encounter, or is the note the legal record of the encounter? And that's a question I haven't been able to find a good answer to. Having said that, I think it's not going to go away. It's going to be an inherent part of our practices moving forward, and I'm so happy that it's there. So if anyone's got any insights on how those risks and potential solutions, I'd love to hear about it.
There are companies that don't just do the scribing, but they provide the nudges in real time to the clinicians. But those are typically companies that have a human in the loop, right? So that they can provide on the fly, Dr. Ehrenfeld, you forgot to do this portion of the exam or provide this important detail. And obviously, I think there's a lot of movement in this space. There are a bunch of companies that are working on it. I'm excited because I think these things will be better. I saw 19 patients yesterday, and at least twice I walked out of the exam room and I couldn't remember some detail that I had to go back and double back on, right? And so that problem goes away with some of these approaches of the technology.
By the way, Dr. Ehrenfeld, let me just ask this question. Do you have to get consent to actually deploy any of these technologies, the ambient listening technologies? Or, do you say to patients, hey, there's a microphone on, or is that kind of an understood part of the whole process?
My understanding is that that's very state specific, but the AMA has some implementation guides if folks are interested, you can find on our website.
Let's start to summarize, because we do have a lot of more questions I want to get over. So taking all this into consideration, what's the future of patient engagement? What does it look like? We talked about the future of AI and patient engagement. That's the title of this. So what does it all mean?
I think the future is bright. We have to implement these solutions carefully with direction and purpose, but we just can't stop at patient engagement. We have to bring our clinicians in and also educate them on how to converse with patients, because I think that's a lost art. When I trained back 20 some years ago, you learn on the fly and you learn by imitating somebody, right? This doctor spoke well, so I kind of follow their narrative. But now with the siloed healthcare system and residency programs really focusing on really focused specialties, that art is lost. And one of the things that one of our goals at Hyatt Technologies is to really bring that conversational educational component into the healthcare space. Empathy training, difficult conversation training, using augmented reality and virtual reality tools as well. So I don't think we can just stop at patient engagement. We have to continue pushing forward and get our clinicians engaged as well.
John, you mentioned that JAMA Open study about empathy and how there was the headline that the AI tools were more empathetic than the physicians. And if you really read into that study, what you find is not surprising. It's not that I don't know how to be empathetic, it's that I'm exhausted and tired and burnout. And the 20th time I have a patient, refuse a vaccine that they need that will protect them and their families, it's exhausting, right? Where do I find that empathy inside of me when I'm trying to get through my day? The machines never tire out, right? As they are pulling on large language models to provide the right words in the right moments. And so figuring out how we can marry these technologies with what we can do as humans, I think is where the art is going to meet the science. And I'm optimistic that at the end of the day, we will find approaches and paradigms that let us be more effective at engaging our patients and getting them to better patient outcomes.
Dr. Topol?
Well, I agree, certainly. I think the other thing to extend on what we've been discussing is, restoring this relationship, which is engagement for patients, but also the care, the bond between physicians and patients, nurses and patients. So one of the other outgrowths of the ambient note, conversation notes that we just discussed, I think you may have seen, John, is that not just that comparative study of Reddit physicians versus the actual physician response to questions. There have been several studies like that. But what's fascinating is to see when you have had the conversation and you put it into GPT-4, that you get all sorts of feedback about how you could have been much better communicator as a physician, how you could have been much more empathic and sensitive. And it wouldn't be at all surprising to me in the times ahead that this will be a requirement for physicians to have. It isn't that the machine understands empathy, but just because it has been pre-trained with the what exemplifies empathy, it can actually coach physicians to be better doctors and communicators. So I think this is something that is we're going to be taking advantage of in the times ahead.
Eric Smith?
I think there's a huge opportunity to have a health coach for a patient. It's driven by the protocols, it's driven by the outcomes the provider is really driving, but it's the 24/7 availability of a coach that's available to you through this AI that speaks on your terms. So if you're an extremely well-educated individual or you know about your particular condition, then the AI may treat you and engage with you differently than if you're somebody that maybe doesn't have the same level of education or awareness on your particular condition that you're trying to manage, and it can adjust accordingly. And on the back end, it's feeding that engagement data back to the provider to know, hey, if I have a panel of 100 patients, who are the 5 that I really need to spend some time with because they're not engaging, I don't see them making the progress that they need to make, or it's clear based off the feedback from the AI that they have questions. Maybe they haven't explicitly or overtly said it or stated them, but they clearly are not understanding of the direction they need to go. So I think there's a huge promise there, and I don't think it's that far away, honestly.
And I think it's really exciting, as Eric was describing, to think about what that coaching can look like for physicians and for other healthcare workers. The AMA has a precision education pilot going on right now that's really promising. A 10-minute interaction with a tool that looks at the physician's electronic health record, sees what patients they're going to see the next day, and then serves them up sort of CME nuggets, pearls on demand that are relevant to what they're about to encounter. A 10-minute interaction can change 2 decisions a week. So you think about how we can use these tools to provide more targeted precision education, both in formal training, but also for those of us in practice as we're trying to do our day-to-day work, is super exciting to me.
We're going to get to some questions, because some more questions. That's been a great discussion. I want to thank all of you. And I want to start, there's a bunch, but I love this one particularly, where I want to read it exactly as they wrote it. What is your holy grail space that you don't want to see AI touch? What would that be? Anyone chime in? The holy grail space. Is there one?
Personally, I don't know that there's one. I honestly think it's patient dependent. So I'll give an example. If you have somebody that's a marathon runner and you have to convey to them, and that's their passion in life, and you convey to them that because of an injury, because of a condition, they won't be able to do what's passionate about them. There's a level of empathy that they are looking for, very similar to where if you shared with somebody that they are about to embark on a cancer journey, there's elements of AI that may not be appropriate there because they just need a human touch. So I think it's very patient dependent and it's very condition specific.
I would have to say it's really authority and agency of the clinicians that they cannot touch that. End of the day, we're the responsible party. We still carry every single patient with us after the day. I mean, Dr. Ehrenfeld, 19 patients yesterday. He's still thinking about them when he goes home tonight. Did I do that right? Did I do the best that I can? So I think maintaining our authority and agency is really, really important. And that's how you can build trust. To the point about empathy, by the way, I mean, I think the way to build it is really experiential. It's not just through talking back and forth. You have to have these experiences in order to understand why that patient is sitting there in a bad mood in front of you, even though you may say, oh, it's just a knee sprain, right? What is going on in that patient's brain? And that takes practice. And you can't practice on a patient anymore. You can't show up on a Tuesday morning, tell a mom that their kid is no longer going to get off the ventilator because of this, that, and the other. You have to have those conversations. And it's a form of harm reduction in healthcare, not just on the patient side, but on the clinician side, because we still go home every single day thinking about our patients. And that contributes to our whole mental wellness and how we treat patients as well. Because if I'm not well, I won't be able to treat someone else well, as Dr. Ehrenfeld mentioned earlier.
Another question that's come in is, it says, we talk about AI within the relationship of patient and provider, but how do you see AI helping the marketing piece of a health system, and what might that look like? For example, can AI help marketers work smarter and more efficiently to gain better patient engagement?
Well, John, I hope we don't have the sort of arms race. I remember driving through a large city in the South, seeing the billboards for the health system that had robot X for procedure Y. I don't think that that's actually going to be productive for the healthcare system as we think about improving quality and costs. But I do think that there are lots of ways to use these tools to help get the right care to the right patient in ways that are beyond our imagination today.
Okay. One more. Go ahead.
The word marketing healthcare is at first glance a bit scary. Maybe communicating appropriately is a better term to use, and bringing patients into the wellness space and really merging health and fitness as the new paradigm shift going future, right? Wellness and I think wellness is going to be the way to talk to patients about their care, as opposed to this kind of siloed diagnosis that they have. You have hypertension, here's some pills. You have knee arthritis, here's some shots. But really looking at the patient as a whole, and then all of us, all clinicians, whether you're an orthopedic surgeon or a heart surgeon or a primary care physician, utilizing the full potential of these tools to bring patients forward out of this healthcare crisis that we're currently obviously facing.
Yeah, I would agree that transitioning from that term marketing to communication, I think, is key, because I don't know if we're necessarily marketing to them as much as trying to educate. Here's why it's important for you to get your annual wellness visit. Here's why preventative screenings are important, right? And being able to target that. This is where the AI piece comes in, be able to target that at certain individuals and communities that we know are at risk, and helping it put it in terms that they understand. I think that's where we can communicate differently with these tools.
Yeah.
And this leads to the next question. It says it's a great step to get the clinicians and algorithm developers working together. But how can the voice of the patient be a part of this development?
One of the things is to allow them freedom to not be anxious, and to make sure that they're comfortable asking you questions. And we know actually from studies that virtual humans are more trusting than real humans in that interaction. You're more likely to ask a fake character that you recognize as being fake a question that is very sensitive to you than an actual human. And that's just human nature, right? I mean, if I know it's not real, and it makes sense, if I know it's not real, I'm going to ask him like, hey, when can I have this particular thing after my shoulder surgery, right? So that's important. And also connecting with the patient on their own voice is important too, right? So having characters that speak to the patient, that look like the patient, that have the same tonality as the patient is also, I think, very empowering to improve that level of engagement and trust.
I mean, John, we want tools that incorporate the voice of the end user. And so for a clinical tool that we use in a healthcare setting that's used by a physician, we want the physician's voice at the table throughout the implementation. Same thing for a patient-facing tool, right? Patient-facing tools ought to have patients that are guiding and advising the development of those technologies.
Well, we certainly have covered a lot today. We have a few more questions. We're not going to have time to address them, but we can respond and follow up with you directly on those questions. But I want to thank all of you for joining me today. I hope people have found this information valuable. I've learned a lot new terms today, too, on how we can describe artificial intelligence or augmented intelligence. And please feel free to take another moment to check out our resources, fill out our survey. And as I mentioned at the beginning, the webinar will be available on demand in the coming days. So I want to thank you all again for joining us, and I hope you have a wonderful rest of day.
Thank you for the opportunity.